Hey everyone, and welcome back to The Explainer. Today, we've got a highly requested masterclass specifically designed for the Anesthesia Learners Academy. So if you're a postgraduate learner gearing up for your advanced fellowship exams, you are in exactly the right place. We're going straight into the absolute highest yield, most heavily tested concepts in postoperative pain management. We're skipping all the fluff and focusing purely on what you actually need to know to crush the boards and, honestly, to excel in top-tier clinical practice.
To pull this off, we're distilling massive amounts of data from gold standard texts like Morgan and Mikhail's Clinical Anesthesiology, right alongside the latest guidelines and systematic reviews. Just think of this explainer as your rapid visual study guide. We're taking hundreds of pages of complex pharmacology, physiology, and evidence-based medicine and turning them into clear, super digestible concepts.
So, here's our exam blueprint for today. 1. Post-operative pain management goals. 2. Systemic pharmacological strategies. 3. Regional and neuroaxial techniques. 4. Chronic post-surgical pain prevention. And 5. Complex patient populations.
Let's dive right into Section 1, Postoperative Pain Management Goals, and exactly why effective analgesia matters so much. It's pretty easy to think of pain management as simply making sure the patient is comfortable. But on your exams, you've got to prove you understand the systemic stakes. Henrik Kellett famously outlined that the goal of analgesia isn't just subjective comfort, it is literally to reduce the magnitude of the surgical stress response and get that patient functioning again. If we fail to blunt this response, the consequences are severe across literally every organ system. Looking at the cardiovascular system, sympathetic stimulation drives tachycardia and hypertension, which dramatically increases myocardial oxygen demand and the risk of ischemia. In the respiratory system, thoracic or abdominal pain causes diaphragmatic splinting, which leads to atelectasis, retained secretions, and hypoxemia. We also see gastrointestinal ileus, a massive neuroendocrine stress response that triggers hypercoagulability, and of course, severe psychological distress. So remember, pain is not just a symptom, it's a major catalyst for postoperative morbidity.
Moving right along to Section 2, Systemic Pharmacological Strategies, also known as your Multimodal Toolkit.
Now, what's really interesting about this is the modern standard of care. What your examiners absolutely expect to see is a multimodal, opioid-sparing approach. On one hand, we've got opioids. And yeah, they're still the heavy hitters for acute nociceptive pain, for sure, but they bring a lot of severe baggage. Postoperative nausea and vomiting, respiratory depression, ileus, and patients build a tolerance incredibly fast. On the flip side, we have non-opioid adjuvants. And the goal here isn't just to use fewer opioids, it's to actually target alternate neural pathways at the exact same time. By attacking pain at different receptor sites in both the peripheral and central nervous systems, we give patients far superior dynamic pain relief, and we actually prevent central sensitization from happening in the first place. These non-opioid adjuvants are incredibly high yield for your exams, so let's walk through them methodically. First up, ketamine. It's an NMDA receptor antagonist. The big clinical pearl to remember is that it stops the wind-up phenomenon and prevents central sensitization, which is absolutely crucial for major surgeries. Next, we have gabapentinoids, like pregabalin. They work on presynaptic calcium channels to decrease neuronal calcium influx. These are fantastic for reducing allodynia and staving off that opioid tolerance we just talked about. Then, there's intravenous lidocaine. Beyond just acting as a local anesthetic, it actually has potent systemic anti-inflammatory properties. That makes it a heavily evidence-based choice, particularly for GI surgeries, to accelerate bowel recovery. Finally, alpha-2 agonists, like dexmedetomidine and clonidine. They work at supraspinal and spinal sites to give potent analgesia and sedation, all without compromising the patient's respiratory drive. Make sure you memorize these mechanisms and pearls, guys, because they are guaranteed test questions. And speaking of highly tested material, you need to commit this specific number to memory: 1.5 to 2.0 milligrams per kilogram per hour. That is the standard evidence-based intravenous lidocaine infusion rate. And here's a huge example for you. To maximize its preventative analgesic effects, this infusion should typically be initiated with a bolus at least 30 minutes before surgical incision, and then it can be continued right into the postoperative period.
All right, Section 3, Regional and Neuroaxial Techniques, Targeted Pain Interventions.
So fellowship exams love testing not just how to do a block, but the evidence-based indications for why we do them in the first place. Let me pose this directly to you. When is epidural analgesia truly indicated over just standard systemic options? Think about those major abdominal or thoracic cases. Before we look at the answers, try to actively recall the proven outcome benefits.
Well, the crucial point here is that epidurals aren't just about getting better pain scores. They are about profound outcome improvements.
According to major meta-analyses, when compared to systemic analgesia, epidurals are associated with a staggering 40% decrease in overall mortality. There's also a reduced incidence of atrial fibrillation and a lower risk of DVT because the sympathetic blockade actually improves blood flow. Plus, you get decreased respiratory depression and pneumonia since the patient can actually cough and breathe deeply without being in agony, and there's a significantly faster return of bowel function.
These regional techniques are basically the cornerstone of ARRES, enhanced recovery after surgery pathways. Notice how sequential this workflow is. First, we actively minimize baseline opioid use before the patient even rolls into the OR. Second, we maximize targeted regional and neuraxial blocks intraoperatively to completely shield the brain from surgical nociception. Third, when they hit the PACU and the ward, we use scheduled, and I mean scheduled, not just PRN, non-opioid adjuncts. And fourth, because the patient isn't snowed by heavy opioids or suffering from unmanaged pain, we can get them moving. We encourage early ambulation and enteral feeding, which drastically expedites getting them safely discharged.
Which brings us to Section 4. Chronic post-surgical pain prevention, stopping the transition.
This is where we confront a truly dreaded complication, chronic post-surgical pain, or CPSP. Your exams are going to test your understanding of how acute pain management in the PACU directly dictates long-term patient outcomes months down the road. First things first, you have to know the exact diagnostic criteria. CPSP is defined as pain persisting for at least 2 months following surgery. Crucially, you have to rule out ongoing tissue injury, infection, or tumor recurrence. On top of that, CPSP often features a distinct neuropathic component, so patients might describe it as a burning or shooting pain, which is very different from the typical dull ache of a healing incision.
So how do we actually stop this transition from acute nociceptive pain to chronic neuropathic pain? The evidence strongly points to these pharmacological prevention strategies. It all starts with aggressive multimodal control, because severe acute pain is the single biggest predictor of chronic pain. We also use intraoperative ketamine infusions to modulate those NMDA receptors and literally stop central pain memory from forming. IV lidocaine is leveraged to inhibit polymorphonuclear leukocyte priming, reducing systemic neuroinflammation. And whenever it's appropriate, we utilize continuous regional nerve or plexus catheters to extend high-quality, totally opioid-free analgesia well into the recovery phase.
Finally, Section 5. Complex patient populations, managing the hard cases.
Listen, on a fellowship exam, you will absolutely be presented with a patient who has a pre-existing pain or substance use disorder. It's guaranteed. So here's the scenario. You've got a patient presenting for major surgery who has been on high-dose opioid therapy for years. How do we manage them without triggering acute withdrawal or just seeing catastrophic pain scores?
Here are the definitive, punchy rules you need to apply for these patients. First, you must maintain their baseline opioids, typically giving 50% to 100% of their normal dose just to stave off acute withdrawal. Second, you need to expect their surgical analgesic requirements to be significantly higher due to tolerance and opioid-induced hyperalgesia. Third, this is the exact population where you absolutely have to maximize regional anesthesia. Fourth, when you're using a PCA pump, you'll need to program larger bolus doses and, unlike with your opioid-naive patients, you'll very likely need a background basal infusion. And finally, heavily employ non-opioid adjuvants, especially ketamine, to really help reset those pain thresholds. And this brilliantly illustrates the underlying reality of treating these complex cases. This quote perfectly defines the total pain concept. When you're dealing with patients who have persistent pain syndromes, substance use disorders, or even severe anxiety, you have to recognize that their pain score isn't just measuring surgical tissue damage. It is this complex amalgamation of physical, spiritual, emotional, and social distress. Now, while you're the anesthesiologist and not a psychiatrist, recognizing this total pain burden is totally vital for setting realistic recovery goals and simply showing empathy to your patient.
To sum up the clinical expectation for these chronic pain patients, you just need to remember this incredibly practical, memorable pearl, the rule of threes. Compared to a standard patient, the chronic pain patient is going to need 3 times the amount of analgesia, they'll need it for 3 times as long, and despite your absolute best efforts, they are still going to tell you they are 3 times as sore. Prepare your team and honestly, more importantly, prepare the patient with these realistic expectations right up front.
Which brings us to a final pretty provocative thought to leave you with as you study for your exams and build your future careers. With the rise of ERAS and these multimodal strategies, the boundaries of our specialty are really expanding. As surgery evolves and continues to become less invasive,
Will the anesthesiologist's primary role shift away from simply keeping a patient asleep in the OR and move toward being the primary physician responsible for preventing the chronic pain epidemic? It is a fascinating paradigm shift to think about. Thank you so much for joining me on this explainer. Keep reviewing these concepts, study hard, and best of luck on your fellowship exams.